Hello, welcome. My name's Julian Savulescu. I'm the Chen Sulan Centennial Professor of Medical Ethics in the Yonglou Lin School of Medicine. It's a great pleasure today to welcome Professor Larry Temkin, who's Distinguished Professor of Philosophy Emeritus at Rutgers University. In the philosophy faculty, he was for many years the head of philosophy. And for those of you who don't know, Rutgers is one of the highest ranked philosophy departments in the United States, if not the highest ranked. So I've known Larry for some years, but I've known of his work for many more years. When I started in practical ethics, I was told you have to read his book on inequality. The full title is Inequality, Rethinking the Good, Moral Ideals and the Nature of Practical Reasoning. So this is the most rigorous, in-depth, broad-ranging, compelling defence of equality in the literature. So, we have tonight, arguably, I believe, the sort of greatest philosopher speaking in defence of equality. Larry also gave the Uhiro Lectures in Practical Ethics in 2017, the most prestigious lecture series in practical ethics. So tonight he'll speak on inequalities and health for 40 minutes. There should be a handout. Has everyone got their handout? This is a style in philosophy that don't use PowerPoints. They use handouts. And then there'll be 20 minutes of questions. So please join me in welcoming Larry.
Thank you, Julian, for that very generous introduction. It's my great honor to be delivering the 2025 Center for Biomedical Ethics Global Ethics Lecture at this world-class university in this world-class city. As many of you know, Julian is the rarest of academics who combines genuinely first-rate scholarship with genuinely first-rate managerial leadership and fundraising abilities. I don't know anybody else who combines that combination of skills in quite the way that Julian does. I've been the beneficiary of those talents on various occasions, and I'm most grateful for that. Thank you, Julian, for inviting me to give this lecture and for hosting me during my visit. Also, thanks to your wonderful staff, Sarah Kay, and especially Connie Wu, for all that they have done organizing this amazing event, and all they have done on my behalf. Finally, I'd like to thank the Dean of the Medical School, Professor Chong Yap Seng, for his role in hosting my visit and supporting this event. Thank you so much. I don't ever wear ties, by the way, ever. But this tie was a gift from Julian. I thought, if I don't wear it tonight, it will never, ever be worn. So I'm wearing it. A brief outline of my talk is on the handout. Part 1, introduction, I begin with 2 vignettes. First vignette. My children were born in Methodist Hospital in the heart of the Texas Medical Center in Houston, Texas. Although this was almost 40 years ago, the hospital's entryway resembled a 5-star hotel where customer service representatives stood behind long marble counters, and there was a huge open foyer, which included, as I recall, an escalator several stories high, a high, gorgeous fountain, large arrangements of fresh flowers, statues, marble floors and columns, and an incredibly high vaulted ceiling. The hospital's new birthing rooms were opulent with large private rooms, mosaic tiling, a spacious private bathroom with a jacuzzi tub, lots of seating for visitors, a comfortable couch that could be turned into an extra bed, a TV, a sound system, a telephone, and soft lighting. An expectant mother never had to leave the room before, during, or after her delivery. Children born into these rooms were quite literally born into the lap of luxury. Unsurprisingly, Methodist Hospital was a private hospital where only the well-to-do, or in my case, the well-insured, could afford to stay. Suffice to say, the conditions were a little different at Houston's main public hospital, where the poor and the uninsured gave birth. Dickens's famous title, A Tale of Two Cities, chillingly resonates with modern-day Houston. In the very shadows of the city's glorious skyscrapers lie barrios and ghettos within which the infant mortality rate exceeded that of many developing nations. Moreover, many of Houston's poor often did without needed medical care, even as but a few miles from them, the Texas Medical Center provided world-class treatment to oil-rich sheiks and other wealthy patients from around the globe. Second vignette. My cousin's third child was born severely premature in Los Angeles, California. Fortunately, he spent his first 3 weeks in a critical care unit for premature infants at LA's Cedars-Sinai Hospital, one of the great hospitals in the United States. The bill for those 3 weeks exceeded 500,000 US dollars, which would be worth about 1.5 million Singapore dollars today. And surely that bill and the services it bought far surpassed the reach of most of LA's uninsured or underinsured residents whose children born with similar problems may well have died. And of course, even as extreme and costly measures were taken to keep my cousin's child alive, countless children around the globe died because they had not received a simple vaccine, package of oil rehydration salts, dose of vitamin A, or antibiotics. If, for the sake of simple and conservative calculation, we assume that the full cost of providing life-saving medication to certain children in the developing world at that time might have been 500 US dollars, it's more now, then for the same amount it cost to save my cousin's son, one might have saved more than 1,000 children in the developing world. But surely those who die due to lack of basic medical care that is widely and cheaply available in much of the world are no less deserving of life or assistance than their counterparts in the developed world. It's just their bad luck, as it were, that they were born in the wrong place at the wrong time and were in the wrong class and to the wrong parents. The preceding vignettes highlight for many the appeal and importance of equality in our considerations about health and health care. We don't merely recognize the sad but inevitable truth that some people are in poor health or receive little or substandard health care and see the pressing need to address the situation. We rankle, some of us anyway, at the further fact that there is so much undeserved inequality in the distribution of health states and health care. For many, I among them, the situation is not merely unfortunate, it is terribly unfair. And this provides significant additional force to the legitimate claims of many in poor health. Of course, such vignettes do not provide an argument for equality significance, nor are they intended to. I've given many arguments over many years and many papers. But they help highlight, I think, a concern that many share, including, I'm guessing, many in this room. In this talk, I briefly present a version of egalitarianism that I have defended elsewhere. I then discuss several complicated issues and sketch some of the implications that our views about these issues may have concerning the distribution of health and health care. Part 2, understanding equality. Equality as comparative fairness. Egalitarians come in many stripes. Too many, I'm afraid. Numerous, quite distinct positions, ranging from utilitarianism to libertarianism to Rawls's maximum principle, have been conflated with egalitarianism, thanks sadly to Amartya Sen, a friend and brilliant economist. Though these positions have little in common. Here, in discussing equality, it's extremely important that one be clear about the sense in which one is using the term. If I give one piece of candy to Andrea and two to Rebecca, Andrea will immediately assert unfair. This natural reaction suggests an intimate connection between equality and fairness. Arguably, concern about equality is that portion of our concern about comparative fairness that focuses on how people fare relative to others. So, on my view, which I call equality as comparative fairness, concern for equality is not separable from our concern for a certain aspect of fairness. They are part and parcel of a single concern. We say that certain inequalities are objectionable because they are unfair, but by the same token, we say that there's a certain kind of unfairness in certain kinds of undeserved inequalities, two sides of the same coin. Many egalitarians seek to rectify the influence of luck in people's lives, and the canonical statement of their view holds that it is bad when some people are worse off than others through no fault or choice of their own. I first formulated that statement in 1977. My view helps illuminate the ultimate role that luck plays in egalitarian thinking, as well as the relevance and limitations of the well-known through no fault or choice of their own clause. Among equally deserving people, it is unfair for some to be worse off than others through no fault or choice of their own. But among unequally deserving people, it isn't bad because not unfair for someone less deserving to be worse off than someone more deserving, even if the former is worse off through no fault or choice of her own. Thus, on reflection, luck itself is neither good nor bad from an egalitarian perspective. Egalitarians object to luck that leaves equally deserving people unequally well off, but they can accept luck that makes equally deserving people equally well off, or unequally deserving people unequally well off, proportional to their deserts. In other words, luck should be approved or opposed only to the extent that it promotes or undermines comparative fairness. So throughout this talk, the version of egalitarianism that I'm appealing to is equality as comparative fairness. The view that it's bad because unfair for some to be worse off than others who are no more deserving than they. Before proceeding, let me emphasize that all reasonable egalitarians are pluralists. No egalitarian believes that equality is all that matters, but they believe that equality matters some. Thus, for egalitarians, equality is only one important ideal, among others, including perhaps freedom, utility, perfection, and other conceptions of justice. Part 3, the importance of health. What role should concern about health play, or access to health care, in the egalitarian's thinking? To answer this question, we must think hard about the human condition and what really matters most about human existence. I can't pretend to do an adequate job of this here in 40 minutes, but let me at least briefly illustrate the importance of taking up this issue. Aristotle claimed that the highest form of human existence was the life of contemplation. Bentham championed a life of pleasure with an absence of pain. Aristotle and Bentham had radically different views about what mattered most about human existence. But they both would have agreed that a valuable human existence depends, in fact, on certain basic fundamental necessities. Minimally, it depends on physical and psychological preservation, which in turn depends on minimum levels of food, shelter, security, freedom from pain, and good health. Let us focus on health. Some years back, I had a brief bout of food poisoning. It lasted a scant 3 hours, but during that time, I was violently ill. Never do I recall feeling so wretched. I shook with fever and chills, moaned unceasingly, and literally writhed in pain. I counted the seconds, fervently hoping the pain would pass and the waves of nausea would subside. Every 5 to 10 minutes, I would force myself to throw up, and this would bring with it a few moments of brief respite. But within a minute, the bile would again begin to build up in my stomach, and the cycle of misery would start anew. While sick, I self-consciously reflected on my state, as perhaps only a philosopher foolishly would. During that time, I was acutely aware of the kernel of truth in the old bromide that if you don't have your health, you don't have anything. I have a wonderful family, good friends, a rewarding job, and interesting long-term projects, but for 3 hours, they were of zero benefit to me. I knew that my state was temporary, but I wondered how long such a state would have to go on before one would simply want to die. I couldn't imagine living in such a state for even a week, let alone a month or a year or many years. Moreover, I was perfectly aware that my state was surely much better than that faced by the truly, desperately ill. Then and later, I was filled with admiration and compassion for those who courageously face and somehow endure a lifetime of chronic pain and debilitating illness. Good health isn't everything, but it is a lot. Freedom from debilitating illness is more than a necessary precondition to a worthwhile human existence. Arguably, good physical and psychological health constitute a large part of what makes a life worth living. The preceding considerations are oversimplified and they're hardly conclusive, but they are suggestive. Many discussions of inequality focus on the gaps between the rich and the poor. But as large and important as those gaps may be, the gaps between the well and the sick may be even more important. Consider diagram 1 on your handout, where the heights of the boxes represent the level of well-being of society's different groups, and the widths represent the number of people in each group. Diagram 1 conveys the fact that far more people are poor than rich, that most who are ill are poor, and that a smaller proportion of the rich are ill relative to the proportion of the poor that are ill. It also conveys the view that whether one is healthy or ill, it is better to be rich than poor, but it is better to be healthy than ill. Indeed, as drawn, diagram 1 suggests that while the gaps between the rich and the poor are significant, the gaps between the healthy and ill are even more significant. Here I mean seriously ill. Diagram 1 is vastly oversimplified. It's not drawn to scale, and it's merely intended to illustrate a general pattern for which exceptions clearly abound. Still, if one interprets ill in diagram 1 as seriously or desperately ill, then diagram 1 may fairly accurately represent the relative position of the world's better and worse off. Suppose on reflection, we think that the world can be accurately represented somewhat along the lines of diagram 1. This, of course, would have important egalitarian implications. Instead of focusing on improving the lot of the poor, there would be strong reason to focus on improving the lot of the ill. To be sure, there would be reason to focus on the ill poor before the ill rich, but there'll also be reason to focus on the ill rich before the healthy poor. Indeed, if diagram 1 accurately represents how people fare relative to each other, then increasing the income or wealth of the healthy poor would reduce the gap between the healthy poor and the healthy rich, but in doing so, it would increase the gap between the healthy poor and the ill. This would be akin to improving the lot of some who were, in fact, already among the world's better off in terms of what matters most. And this might, in fact, worsen the overall inequality of the situation. I have focused on health as a large and necessary component of human well-being. But obviously, health alone is not a sufficient component of human well-being, and there may be, and indeed are, other components that play similarly central roles in our lives. As touched on earlier, these may include minimal levels of food, shelter, security, and freedom from pain. Moreover, there are other, less tangible goods like freedom, autonomy, or love, without which human lives would be significantly lacking in value. Unfortunately, here as elsewhere, there's no substitute for deep and substantial thinking about the nature of the human condition and the good. What are the most necessary, central, and valuable items for human beings? How are these components of well-being related and distributed? Until such questions are answered, it's impossible to determine to what exactly egalitarians are committed. Let me be clear. I am not, in fact, arguing that we have reason to be complacent about the extraordinary gaps in economic inequality that pervade our world. Indeed, as has been amply demonstrated, there are important correlations between economic success and the other components of well-being that I have been emphasizing. Still, our results may have important implications regarding the aims and focus of egalitarianism. To a large extent, the current battleground of egalitarianism is an economic one. Egalitarians rely heavily on economists to meaningfully measure disparities in income and wealth. And political programs are developed and advocated with the goal of reducing economic disparities. But if the inequalities that matter most are actually inequalities of food, health, safety, and the like, then there may need to be a profound shift in the tools, approach, and policies of egalitarianism. Perhaps egalitarians need to consult doctors, nurses, nutritionists, agronomists, or political scientists. Perhaps they require meaningful measures of serious illness, nutritional deprivation, human rights realization, or political stability, at least as much as measures of economic inequality. Similarly, perhaps the focus of egalitarianism needs to change from efforts to shift the wage scale, alter people's savings habits, or redistribute wealth, to altering the focus and distribution of medical care, increasing crop yields, changing patterns of nutritional consumption, or promoting political stability or human rights. In sum, once one gets clear about what really is most important for the living of a valuable human life, how that is distributed amongst people, and how variations in distribution would actually affect inequality, the assumptions and policies of contemporary egalitarianism may require revision. Part 4, equality of well-being, equality of opportunity, and the first come, first serve principle. Equality of one kind will often require inequality of another. For example, equality of income may correlate with inequality of need satisfaction between the handicapped and the healthy. Many assume that concern for one kind of equality rules out concern for others. However, on a pluralistic view, that assumption is a deep mistake. My own view is that a large component of the egalitarian's concern should be with equality of welfare or well-being, roughly how well off people are. However, I also think that the egalitarian should give weight to equality of opportunity. They're both important. So, for example, ideally, we might want everyone to be in equal state of high-quality health. If, however, the prevalence of disease and scarce medical resources makes that impossible, we might at least want everyone to have an equal opportunity for high-quality health, or for as good a health state as is reasonably possible. Equality of opportunity plays a central role in debates concerning universal health care, underlying the notion that everyone who is ill should have equal access to the same, or at least a sufficient, level of health care. Equality of opportunity also plays a central role in debates about rationing. In the face of scarce medical resources, where not all medical needs will be met, What system will ensure that everyone at least has an equal opportunity to have their needs met? In the context of organ transplantation, when there are not enough healthy organs for everyone who needs them, at least not now in most cases, there's widespread agreement, at least in many countries, that special preferences should not be given to the rich, famous, or powerful. That would, it seems, be patently unfair. To be sure, it may not always work out in practice the way it's supposed to, but complex systems have been set up in many countries to ensure equality of opportunity in the distribution of organs by giving weight to such considerations as the urgency of the patient's need, the match between the organ and the patient, and how long the patient has been in the queue, not to the size of their bank account. Each of these elements can be justified on grounds of equality of opportunity if one regards the relevant facts in these cases to be determined by the natural lottery, and if one believes, as the Harvard philosopher John Rawls and others have contended, that any distribution resulting from such natural lotteries are fundamentally not unfair. I myself have grave doubts about the view that we should complacently regard the distribution of benefits and burdens by the natural lottery as not unfair. I think that's wrong. But I understand the source of the intuition. Nature, it is assumed, is a great equalizer. Like justice is supposed to be, nature is blind, dispensing her benefits and burdens without regard, in theory, to such factors as race, gender, creed, nationality, status, power, or wealth. We all know that's actually false. A word about the role that first come, first serve plays in medical thinking. Some years ago, I spent a year at Harvard's Safra Center for Ethics. One of my colleagues was Dr. Walter Robinson, a pediatric pulmonologist, who asked us our view of a scenario that went something like this. A child had come into the pulmonary care unit of a children's ward, desperately needing the use of a particularly expensive machine, of which there was only one. This was a true story, by the way. This actually happened to Walter. He was hooked up to the machine, but it was estimated at the time he was hooked up that even with the machine, his chances of survival were only about 5 or 10%. As fate would have it, soon afterwards, a second child was brought in, which also needed the machine, and there were no other nearby hospitals with available machines. The doctors estimated that if the second child were not hooked up to the machine, he would almost certainly die. But that if he were hooked up, he would have about an 80% chance of survival. But of course, for the second child to be hooked up, the first would have to be unhooked and hence face almost certain death. Most of us thought that, tragic as it was, the first child should be unhooked and the second child should be hooked up. Our thought was mainly that doing this would meet two fundamentally important moral criteria. First, it would maximize the chance that at least one of the children would live. And second, assuming that the nature of the children's illnesses and chances of survival were determined by the natural lottery, it would not be particularly unfair if we let such facts determine our actions in deciding how best to satisfy patient needs, given the condition of scarce medical resources. In the real case on which the scenario was based, the first child was left on the machine, and both children, predictably, died. I believe the hospital's reasoning involved at least two important elements. First, they avoided the option of depriving the first child of almost any chance of survival, though when they made their decision, they surely must have recognized that a second child might subsequently arrive on the scene who would also urgently need the machine, and who might have a much better chance of survival if hooked up to it. Who can blame them for this? How would they have felt if no second child presented itself and they had let the first child die without even trying to aid it? Second, in hooking up the first child, they justified their decision as following the first come, first served principle, which can be seen as reflecting the important principle of equality of opportunity. But then, having hooked the first child up, they had two powerful professional obligations not to unhook him. First, in accordance with the Hippocratic Oath, to do no harm. And second, to provide the best possible care for their patient, which the first child had become when they took him on and hooked him up to the machine. Notice, in this case, the concern for equality of opportunity might have been met in two distinct ways, which meant the ultimate choice came down to the professional considerations on the one side and the consideration of maximizing the chance of a life saved on the other. But I believe that the importance of the first come, first served principle in such reasoning cannot be ignored. First come, first served will seem a relevant and important principle when and only when it seems fair. This will be so, I believe, when it involves comparative fairness, giving each of a relevant group an equal opportunity to an important but scarce good. Part 5, individual responsibility and the distribution of scarce medical resources. If one believes, as many do, that people can have personal responsibility for their actions in a way that is compatible with a meaningful conception of desert, then, as implied above, not all substantive inequalities will involve comparative unfairness, and hence be objectionable from an egalitarian standpoint. This position is relevant to many important issues in health policy and the distribution of health care. For example, it has deep and important implications for the nature and extent of our obligations to those who require medical attention as the result of their own fully responsible choices, if there are any. This might include conditions resulting from individual choices such as smoking, overeating, and engaging in unprotected sex, as well as injuries incurred on a voluntarily accepted job or sustained engaging in risky behavior such as mountain climbing, motorcycling, or driving without a seatbelt. Clearly, the scope of this issue is huge, and there's much to be said about it, but I have not much time, so let me just make 5 brief points. First, it should be clear the mere fact that some are much worse off than others in terms of their health does not mean that there's an egalitarian reason to aid them. There's an egalitarian reason to aid someone if their situation is unfair relative to others. And whether this is so or not will depend in part on facts of individual responsibility pertinent to the case. Second, even if there's no egalitarian reason to aid the ill or the injured, there are many powerful normative considerations that may dictate our doing so. These include considerations that speak in favor of giving special weight to those who are poorly off, humanitarian considerations to ease pain and suffering wherever it occurs, utilitarian reasons to promote the general well-being, virtue-related reasons of compassion, mercy, beneficence, forgiveness, and so on. As noted earlier, egalitarians are rightly committed to pluralism, and we have to be sensitive to the full range of reasons for aiding the ill that have nothing to do with considerations of equality or comparative fairness. But third, where the other morally relevant factors are equal or even sufficiently close, egalitarian reasons of comparative fairness may well help determine who among the ill has the strongest moral claim on scarce medical resources. So, for example, if one has to choose between who gets the last available bed in the intensive care unit, Perhaps it ought to go to the innocent pedestrian who was struck by the drunk driver rather than the habitual drinker who was driving drunk. Fourth, from the standpoint of comparative fairness, it is crucial to determine appropriate comparison classes so that one is comparing all relevant types of behavior in the same way. For example, it would be objectionable to downgrade the medical claims of an AIDS patient who engaged in unprotected sex if one wasn't similarly prepared to downgrade the medical claims of pregnant women who engaged in unprotected sex, or perhaps obese stroke victims who did nothing to curb their indulgence of food. You can't pick and choose on these kinds of issues. Finally, it's important from the standpoint of comparative fairness that one not merely compare the losers who make poor choices with the winners who make good choices, but that in addition, one compare the winners and losers of both categories with each other. Most smokers don't develop lung cancer. Most people who overeat don't have a stroke, and most helmetless motorcyclists don't end up in the emergency room. Thus, from the standpoint of comparative fairness, it is important to bear in mind that full responsibility for one's choices, if there is such, doesn't automatically translate into full responsibility for one's predicament. Indeed, as the great philosopher Immanuel Kant rightly saw, the two are only loosely connected. Correspondingly, consideration of equality as comparative fairness requires that we pay attention not only to actual outcomes, but to the extent to which different people end up better or worse off than the expected value of their choices. Unfortunately, I cannot pursue these issues here. Part 6, conclusion. In this talk, I've articulated one particular conception of equality, equality as comparative fairness, and sketched several factors that might be relevant on that conception to how we should think about inequalities of health and health care. I'm acutely aware that the issues I've addressed here have been dealt with superficially. Unfortunately, while 40 minutes is a good length of time to sit through, it's not much time to deeply explore any topic. I spent 15 years on my first book, Equality, and 27 years on my second book, Rethinking the Good. So 40 minutes? Can't expect too much. Perhaps, however, I've said enough to provoke discussion and open further lines of inquiry. Thank you for your attention. I look forward to your comments and questions.
All right, so we have plenty of time for questions. Maybe I'll just start off with one question, which is quite important practically. So you mentioned the pluralism of reasonable egalitarians, and often there's a tension between equality and utility. So how are we to decide this? How much weight are we to give to equality and how much to utility? We did numerous surveys before the pandemic and during the pandemic of how people allocate, say, one intensive care bed, a little bit like your scenario. And we asked about differences in probability of survival, length of survival, quality of life, and so on. And people always went for the individual who had more utility. So they had better chance of survival if it was 80% rather than 70%. It was only, they'd go for the 80%. It was only when the outcomes were very similar did they say, we toss a coin, which we thought was the egalitarians. But maybe not. But I'm wondering how you think we should approach these trade-offs, because in this diagram, you're very familiar with this objection. One way to achieve equality is what's called levelling down. You sacrifice the utility of people in the better off group and provides more utility. And in practice, that's often what you have to do. You have limited resources, you divert it from the people who are better off to the people who are worse off. So I'm wondering how you deal with this trade-off between utility and equality.
Thanks, Julia. Appreciate the question. Great question. I have a whole bunch of things to say about this. I'll just say a few things. First thing won't surprise him, may not surprise any of you. I'm a philosopher. I'm not particularly concerned about what people do or don't vote on when you put a bunch of questions before them. That's just me. We can debate that argument. I know you and many other people have made a career asking such questions. I have lots of worries about that as a way of resolving the ethical questions of what we should do. I don't think that's determined by vote. So that's the first side point. It's not really important to the central question you're asking. The question is about how you trade off between utility and equality, or utility and equality and freedom, or utility and equality and freedom and autonomy, and all these other things that matter. There's no simple answer to that question. Neither I nor anyone else thinks that we have a simple answer. Any such answer will be very complicated. But there are two very important things to point out. The first thing to point out is that we need to get away from the idea that there is a precise answer, the idea that the utilitarians have given us to every one of these questions. In theory on utilitarianism, there's always an answer to the question of which of two alternatives maximizes good, even if it's by a little teeny tiny iota. I don't think, and I doubt you think, that that's the right way to think about ethics or about values. I think there are lots of different values. I think they all matter, but they matter to various degrees. But there's no precision. There's no like utilitarian matters, utility matters 2.31456, as the old Spock might have said, relative to 1 unit of equality. It doesn't work that way. So what we actually have when we have to trade off is we have trade-offs between things like there are some clear cases where A would be better than B. There's some clear cases where B would be better than A. And then there's a whole bunch of cases where there's simply no fact of the matter about whether A is better than B or B is better than A. And it's not a matter of ignorance. It's a matter of what we call is a rough comparability between competing ideals and competing alternatives. And we have to get used to the idea that there are many, many cases of rough comparability. So if you're choosing between, for example, I'm spending some time on this question because it's such a central one. So give me a moment to get these two further points out. So if you're choosing between different forms of life, for example, what kind of person should I be? What kind of, job do I want to do? There are some jobs you clearly don't want to do if it's up to you. You probably don't want to be cleaning out the toilets, blah, 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 blah. There are other kinds of jobs which, if you were offered those jobs, you'd love to do. Your favorite job paid you $1 million a year. Then there's other kinds of jobs where you could maybe be a philosopher making, good money but not great money, or a lawyer making pretty good money, better money, but it's a less interesting job maybe to you. And now there's just no fact of the matter. These are both on a par. It would be rational to do either one. You could be the lawyer, you could be the doctor. Now the answer to your question, such as I have here, is that there's going to be a lot of cases where the utilitarian considerations and the egalitarian considerations go in the same direction. In that case, it's easy. Do what they both say you should do. I'm simplifying as if those are the only two values. But there'll be some cases where they diverge, many cases where they diverge. Now what do? Well, now we get to the case of suppose they diverge in terms of equality by just a bit, but they diverge in terms of utility by a lot. Then almost certainly you should do the one which has the better utility. There will be other cases where they diverge by utility just a little bit, but they diverge by equality a lot. In those cases, you should almost certainly do the thing that is more egalitarian. A little bit of give up in utility, but a great gain in another thing which matters. And then there's going to be a whole bunch of cases in between where it's not anywhere near that simple. And although there may be a determinate answer that goes one way or the other in some of those cases, in many of them there will be no fact of the matter, and either will be morally defensible. I'm not saying in all of those it's much more complicated, but we have a short discussion period. So that's my general answer.
Thank you, that's a great answer. We should ask other people. Owen, do you want to come up?
Yeah, thanks. Thanks for that. I guess I have a follow-up of sorts to Julian's query, but I'll just put a finer point on it. in relation to real-world trade-offs. One current real-world scenario where these dilemmas are being faced is due to, of course, the sudden U.S. withdrawal of aid internationally. And there's now a massive budget crunch in the area of areas such as HIV treatment and prevention. And countries and WHO, and I've had various conversations with these entities, are now scrambling to figure out how to allocate what little resources there are left. Right? So this is a crucial question, and this question is no longer abstract. Right? How much should we weight the value of equality, getting an intervention that many people say receive, but you might be able to save a lot more lives if you pick a different intervention that is going to get a lot more magnitude of benefit for a smaller number of individuals, or so forth, right? And I can tell you that these are actually being quantified, right? You'll get estimates across various dimensions. You'll get estimates of cost effectiveness. You'll get estimates of impact on the budget of the country. You'll get estimates of, also, some people have suggested estimates of equality impact, right? That's been a line I've seen in actual allocative frameworks. And you can say, well, it's vague, and it's up to discretion, and it's an open question. But when push comes to shove, countries and institutions are going to have to make these calls. And Julian suggested, I think, what is a common approach. You said, well, if one is really big and the other is really small, maybe it's clear, but in this one area where they're closer, it's kind of indeterminate. But we have routinely been suggesting actually weighting utility heavier. And let's just give a brief explanation for why, when they're close, utility ends up being weighted heavier. It's just to think about the moral importance. Right? And think about, put a finer point on it, we're talking about saving lives. Right? We're talking about people that will otherwise die. And the basic idea would be that the weight of those lives lost, even if you have you have a lot of equality and a lot of lives lost in both scenarios, it's actually much more important, morally important, to focus on the lives saved. Whereas the equality might matter, but that if you have similar, say, quantities or similar amounts of utility loss or equality loss, you would favor utility. That's just a suggestion. I don't know what you think about that approach when these are literal trade-offs in the real world. Over.
So I have quite a lot to say about this, including the issue about withdrawing aid. I wrote a book called Being Good in a World of Need. And for what it's worth, although I spent my entire life on the Peter Singer line of what you ought to do in order to help people in the world's, the worst off people in the world's poorest countries, I now come down on a different side of that issue. It's not because I care about such people any less than I did before, but because I am no longer confident that doing that is the best way to help such people. So I won't get into the question of whether it's actually, in the end, might actually not be such a bad thing, but it might not be such a bad thing for all sorts of reasons that if you're really interested, you might read that book or Angus Deaton's fabulous book. Now, getting back to the actual question that is underlying your concern, you say in the real world we often go this way. Well, yes and no. I mean, I know people often go that way, but it often goes the other way too. The other way too. I'm going to give you an example from real life. I mean, for a very long time, China, had a particular way of doing things, and then they moved to trying to get a more efficient market, and they let that govern a whole lot of things. So they basically moved to a form of capitalism of sorts in the economic market. And they also moved to a form of capitalism, as it were, in the health care, in the health area. And the main reason they did that was because they felt if they did it that way and they unleashed it that way, it would minimize dollars. And they thought, and one of the reasons this turned out to be the case is that, most of the people, it's the problem of the last mile communities. Many people in this room will know about that. But, in a lot of the poorest countries of the world, there's a lot of population in major centers, and there's a bunch of people who are rural. In the major cities, they have lots of people, and they have more infrastructure, they have more doctors, they have hospitals, they have nurses. You can't have the same doctors and the nurses, and if you want to save all the lives out there, it's going to be rough. It's going to be hard to do. If you want bang for the buck, you're just going to spend the money in the cities, and you're going to not worry about the people out in the rural thing. So in 2002, the World Health Organization released its pioneering work called The Global Burden of Disease. Maybe you know about this. This was headed by Chris Murray at the time. Chris Murray was the inventor of dollies. Up until that time, everything in global health was about minimizing dollies or maximizing qualities. It was all about cost effectiveness. End of story. That's all they cared about. But Chris thought that maybe we should care about equity, maybe we should care about equality. He called me to talk to them at Geneva. He listened to me. He ended up creating an appendix in that volume, that very important volume. And what it did is it not only listed the state of the global health, the global burden of disease, by the effectiveness of various health systems, it also listed by the inequality of various health systems, healthcare and health states in every country in the world. Was listed in the 2002 appendix. This was actually based on my work, diagrams that I had, and so on and so forth. Had a massive impact. Here's the main reason it had a massive impact. Because when the Politburo in China, the committee, looked at the results, they said, we are a communist country. We've been striving to have, dollars. We want bang for the buck. That's all we care about. We want to help save as many lives as we can, as you put it. But really, it's not about lives. It's about minimizing dollars, diseases that don't necessarily kill you, but et cetera. So that's what they were working on. But then they looked at these rankings, and they found that they were very near the bottom. And places like the United States and Great Britain were very near the top. And they said, we are a communist country. We can't. We could be worse than them in steel production. We can be worse than them in a lot of things, but we can't allow ourselves to be worse than them with respect to the quality of health care and health states. And the main reason was because they basically abandoned the rural poor. Well, there were about 800 million rural poor. So they changed their policies. The Central Committee made a concerted effort to adopt an entirely new approach to delivering health care. And basically, as a result of that 2002 appendix, indirectly as a result of my work, they brought health care to roughly 800 million rural Chinese on a yearly basis from roughly 2004 on. Now, if you look at the last 22 years or so of gains in global health, I probably don't have to tell people in this room, there have been massive gains in global health up until COVID and, blips here and there, like what's going on with the opioid crisis in America. Almost all of those gains have taken place in two countries, China and India. And part of the reason the change has taken place in China was due to their consideration about equality and not just efficiency.
Other questions? Morale.
By the way, I think they were right to do that.
Hi, thanks for the talk. So you say you're a pluralist, right? And so you care about utility, you care about the needs of the worst off, you care about whether they have enough. And when you have all these considerations, right, it seems equality just drops out of the picture in that it doesn't seem to suggest all the intuitively plausible, once you account for all the intuitively plausible cases, these seem to be able to accounted by all the other values that you do accept, then equality doesn't seem to have any force in explaining any other intuitive cases.
So I think that's just an assertion, and I think it's false. I mean, I see no reason to believe that. Here's what's true. You can, and this is what people do all the time. They pick a particular kind of case. Julian referred to this earlier, like the leveling down objection. And they say, here's a way you can promote equality. You have people who are blind and you have people who are sighted. I put this in my original thesis back in 1978. And you can make everyone perfectly equal by putting out the eyes of everyone who's sighted. And that'll bring about equality. And nobody thinks that's a good idea. And then you say about that kind of case, and this is what I said, well, it's true. Nobody thinks that's a good idea. I don't think it's a good idea because this is a case where every other thing lines up on the side of not doing it. Rights, it's bad for rights, it's bad for utility, it's bad for humanitarianism, it's bad for blah, 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 blah. It even turns out to be bad for the people who are blind to begin with because the sighted people no longer have their eyes. So in terms of everything else we care about, it's worse. In terms of one thing, it's better, equality. So in that case, we're obviously not going to say all things considered, that's what we should do. It doesn't mean there's nothing to be said about equality. It just means in that case, it all lines up the other way. But it's just false. I'm sorry to think that every case we imagine out there in the world lines up that way. Those are the paradigm cases that people perhaps like you, think of when they want to say we ought not to be egalitarians. They think about certain paradigm cases where there's little equality all by itself over here and everything else goes the other way. I can describe and have, in many cases, many cases, where equality lines up with as many values as you want and some other single value, like freedom, goes on the other side. This doesn't show that freedom doesn't matter. It just shows as if it's just freedom against every other thing we care about, freedom is going to lose out. But if someone uses this kind of argument, as many people have, to show, oh, equality doesn't matter, so I guess freedom doesn't matter either, that's just absurd. But I could give you cases like that, where you have to choose between freedom and everything else we care about. And in that case, we usually say, so much for worse for freedom. But no one thinks as a result of that kind of argument that freedom doesn't matter. Of course freedom matters, but it's not all that matters. I think the same is true about equality.
Thank you. So you mentioned that equality has a value in and of itself. When you say equality, do you always mean equality among all humans? Or is there a value in and of itself to have more equality within small communities, say a nation or a neighborhood? And in the other direction, is there value in and of itself to have equality beyond humanity, with other species, for example?
That's a great question, and I'll be honest, a hard question for people like me. Not hard because I don't have a view about it. I actually have a clear view about it, but hard because some people don't like the implications of my view. So what I think is that it's unfair or unjust for some to be worse off than others through no fault or choice of their own. If that's true, then I think one of the distinctive contributions, if I can put it this way, in my approach to equality, is that I argued against the prevailing standards up until I wrote my work. The standard view about equality was that it was very simple. It was also holistic. It was essentially distributive. So holistic, people said, you care about equality, do you mean you care about equality between men and women, blacks or white, people in the United States versus people in Chad? People always look at groups. And I said, no, if it's unfair or unjust for blacks to be worse off than whites through no fault or choice of their own, then it'll be unfair or unjust for some blacks to be worse off than other blacks through no fault or choice of their own. And if that's true, then it's also unfair or unjust for some whites to be worse off than some blacks through no fault or choice of their own. And this pushes you towards what I call the individualistic approach to inequality. So I'm inclined to think I'm a universalist about these things. I'm an impartialist about these kinds of things. I think whenever one being is worse off than another through no fault or choice of her own, there's something unfair about that. Now again, being a pluralist, does that mean that I care particularly about the state of cockroaches relative to humans? No. No, I don't. But if you're asking me the question, it's a really good question about the scope of moral concern, I don't see how to arbitrarily chop it off and say, well, I care about inequality in the United States, but I don't care about inequality between people in the United States and people elsewhere in the world. I mean, this is what I hate most about the political system in America, for what it's worth, is both the Republicans and the Democrats say, I want to do what's best for Americans, right? I want to change all these trade policies so that these Americans are better off. I understand why someone running for office in America will make that claim. And they'll say, I'm president of America, I'm not president of the world. Fair enough. On the other hand, if the factories are coming home to relatively well-off people in America, and they're being taken away from very badly off people in Bangladesh, I don't think that's a gain. I think that's actually a bad thing. So the scope for me is quite large.
Okay, we've probably got time for one last question. Shang Long.
All right, thanks very much. So I had a question about responsibility in healthcare and specifically how you think that would translate into practice. So, through no fault of or choice of their own, that might be really hard to ascertain the sort of facts of individual responsibility insofar as someone might be making what seems like a choice, but it's because of social structures or family environment or whatever random accident that they chose this way. So I guess in practice, do you think it is ever possible to implement a measure of responsibility in healthcare, or, all things considered, we should just not try to assess it because it's so difficult sometimes to assess our responsibility? Yeah, thanks.
Okay, another great question. I just have to say, this is a fantastic collection of questions. Thank you to each of you for your questions, starting off with yours and all of them following. This is a great question. So, look, I think what I want to say is, for practical purposes, so my mentor, Derek Parfit, was his student going back years and years. I was his first graduate student. We started together in '77, and we worked together our whole lives until he died. The one argument we had every single time we got together, was about moral responsibility. Because Derek argued that nobody was responsible for anything. Nobody's responsible for anything good, and nobody's responsible for anything bad. It's very easy to take a certain objective view of the world. Now I'll invoke another teacher of mine, Tom Nagel. You have an objective and subjective view. From an objective view, it's very hard to find any room for individual responsibility. On the other hand, from the inside, I can't help but think. Doesn't mean it's true. I just can't help but think. This kind of Kantian point. If you can't help but believe that, then for practical purposes, you'll be motivated as if, even if it's not actually true, objectively. That's the Kantian point and insight, and he's right about that. From the inside, if I have a bunch of students submit their grades, I always grade everything blindly. I grade them all blindly. I uncover it all up, and I find out this one student I just hate got an A. I just don't like him. He's, I just can't help it. I just don't like this guy. So I give him an F or a C. Maybe I just give him a C, right? From the inside, that just seems wrong. I just think I didn't have to do that. I chose to do it. I knew I was acting wrongly. I did it anyway, so I feel responsible. Now, going back to the practical question. Practically speaking, it'd sure be a lot easier just to ignore this question about responsibility and just say so many other issues come into play, social stuff and, the way you were born and the genes and the time and the place and the country. And that's going to swamp any role for individual responsibility. So let's not get lost in the weeds worried about these kinds of cases. Let's just treat everybody as if Parfit's right. I won't go to the mat on that. I think there's much to be said for that because I'm very attracted to Parfit's position. I don't actually believe it's true. And since I don't actually believe it's true and I'm a philosopher, I want us to try a little bit harder to figure out what role we might want to pay it and when to individual responsibility. But practically speaking, no, maybe it's okay to say, for practical purposes, we'll just assume Parfit's right, and if we're wrong, okay, well, everyone's going to make some mistakes when you make global decisions. I would lose a lot of sleep if people made that decision. But if you're asking me what I think the truth about morality is, I think the truth about morality is not all cases of inequality are objectionable from an egalitarian standpoint. If Parfit's right, they all are. End of story.
There's a lot of kind of competition for the philosopher that has done the most good in the world, and people often point to Peter Singer as the philosopher that's brought about the most good in the world. But Larry is obviously a hot contender with 800 million Chinese being lifted out of ill health. So I bow down to you. I will never do anything like that. No, seriously, it's a wonderful opportunity to hear the kind of depth and breadth of the basis for concern about equality. And I must say, in this lecture, you've convinced me. But I think you should have pluralist egalitarian in front of the equality. But it was a very, very convincing and fine piece de resistance. So thank you, Larry. Join us for some food outside, and I hope you enjoyed it.
Thanks, Julie.